pleasure to meet you this very moment. Um, it's time to have um, introduction to systemic pharmacology and Autacoid pharmacology. Now, the systemic pharmacology has its own set of components, but first, I'd like to take you through the Autacoid pharmacology in short moment. Then I will later introduce you to the systemic pharmacology, that is the study of drugs that affect the function or that alter the function of the different systems of the body. My name is Chandia Milton, a lecturer in Moni University, and I just want to take this chance to give an outline and illustrations on how Autacoids can help us to reduce inflammation. And I mean, the inhibition of Autacoids can help us to reduce inflammation and also pain. That is talking about anti-inflammatories and analgesics. In some class, we were able to have briefs of this, but this time we are going to take it from biochemical point of view, relating it to the, the use of the common drugs that we usually call them as painkillers. Uh, what are Autacoids? I expect that in this lecture of Autacoid pharmacology, you should be able to um, you should be able to explain the term Autacoid with examples. You should be able to describe briefly the synthesis, storage, and release of the various Autacoids. Then you should be able to explain the physiological effects and mechanisms of action of the various Autacoids. Eventually, we should be able to describe the pharmacology of the various Autacoid agonists and antagonists, including their classification, mechanism of action, and the therapeutic uses, where we should also be able to look at adverse effects and their interactions. Um, Generally, the word Autacoid, the word Autacoid is is a mediator, is a set of mediators that are generated within the body by biochemical processes, and the mediations that they do include some bodily reactions to cause inflammation, as well as um, as well as some um, pain, because the products of biochemical processes within the body generate intermediates that tend to irritate the nerve endings and cause accumulation of fluid or some irritation of the nerve ends. So when fluids accumulate, they cause edema, leading to inflammation or swelling of the body parts. And when um, other intermediates get produced, they also irritate the nerve endings, causing pain. And this kind of response is more protective. It, it informs the body of dangers that are taking place within the body, and makes the person aware of what is going to happen, whether the body parts are getting damaged or not. Then eventually will draw the attention of the people who can give intervention and help such culprits. And it is common in accidents and in places where, in parts of the body where trauma has been caused. Where there's trauma, this kind of biochemical processes come into play, and they either bring protective mechanism or they bring some kind of irritation to alert the body and the mind of the person of what is happening, either to inform the person to withdraw or to look for a way of saving himself. So they are really generally protective mechanisms, but they also end up causing disability or disabling some body parts and bringing the body parts to non-functionality. So we can, for example, look at this from the perspective of what happens to a person when stung by a bee, and what happens when some people take drugs and develop allergy. What happens to people who eat foodstuff prepared from contaminated flour? Or what do they say? And these questions keep, lingering in our mind. Why do females experience pain during menstruation? These, these kind of questions help us to understand the, the, the importance of Autacoids. So why do you think some people complain of constant joint pain and backache, yet they do not carry out heavy duties? These kind of questions help us to understand the pathophysiology of certain disorders that occur in the body. And so uh, the word Autacoids comes from Greek word auta for auto, and akos, which means for cure. So these are pharmacologically active substances produced, stored, and released in response to local stimuli in the body. That's what we mean by Autacoids. So their effects are limited to the site of release. There is also an effective mechanism of their inactivation at the same site of release, which means when these Autacoids get produced within the body and stored, and when they're released, they produce certain responses, and eventually they are inactivated. So their effect does not go indefinitely. Typical examples of Autacoids include histamines, hydroxytryptamine, that is serotonin. There is eicosanoids, bradykinins, and ergot alkaloids. Um, some of you who have gone through biochemistry must have understood how these are generated within the body. Now, these compounds are actually termed as local hormones, or Autacoids, or autocrines. In certain physiological terms, they are called local hormones or autocrines, but they are also generally known as Autacoids. So, in short, we are saying that um, we are saying that Autacoids are pharmacologically active substances produced, stored, and released in response to a local stimuli in the body. And that's what I want you to take in summary. Now, the difference between Autacoids and hormones is that they are produced by many tissues rather than in specific endocrine glands. All cells within our body in any tissue are able to produce Autacoids, and it comes when the cells get destroyed or even get stimulated by a local stimulus. And this stimuli could be trauma, could be pricks, could be fractures, could be injury of any type. That is stimulus. So when released, they cause many physiological changes. When the Autacoids are produced and released, they produce many physiological changes which can be desirable or undesirable. And so they when they produce the effect are short living. And so they have physiological roles. For example, one important physiological role is that in the peripheral tissues, they cause inflammation, they bring, they even cause allergic reactions, anaphylactic reactions, neurotransmission, gastric acid secretions, and so on in the periphery. While in the central nervous system, the autacoids are responsible for causing wakefulness of a person, decrease in appetite, regulation of drinking, regulation of temperature, secretion of uh, secretion of antidiuretic hormone. They also in, they also they also play a role in control of blood pressure, even perception of pain. However, you should note that the peripheral effects predominate the central effects in the body. And so, a good number are of very good physiological use. And now we are going to look at these examples one by one, trying to highlight some of their effects. I know you have known them in biochemistry, but I want to bring it to your attention because we shall go back to understand how we can inhibit the the autacoids when they produce undesirable effects like allergies, like pain, like inflammation. We'll have to inhibit the the we'll have to inhibit the um, production of this autacoid in order to stop the inflammation and pain. And so, one of the typical examples of autacoids is histamine. And this is one of the biological active um, amines present in many tissues. More, they are more concentrated in the skin, lungs, gastrointestinal mucosa, and it is a component of some venoms and stings that are secreted by insects. And it is present in human plasma at relatively low concentrations, but substantial quantities are present in urine. No wonder when you urinate on some skin or even on some wound, it really irritates the wound, fresh wound. So it's not easy. So generally, the synthesis of histamine it originates from amino acid, which is L-histidine, by decarboxylation. The reaction is catalyzed by histidine decarboxylase enzyme expressed in all cells, as you know from biochemistry. And then this histamine produced is stored in secretory granules of mast cells and basophils in the plasma as inactive complex with proteases and heparin sulfate or um, chondroitin sulfate. Chondroitin sulfate. So they can also be rapidly inactivated immediately after release, and it is released from mast cell granules in two ways. One is by um, antigen-mediated mechanism or non-antigen mediated mechanism, which means when an infection occurs, it can stimulate um, release of histamine, or there could be any other mechanism that may not be stimulated by any infection. Rather, it could be as a result of injury, it could be any trauma that could cause, but that is not antigen mediated. So that's one of the mechanisms of production of the antigen, histamine, I mean. So most of the antigen mediated immunologic reactions, and they occur during allergic and anaphylactic reactions. And the mechanism is that antigen, which is the allergen, stimulates the release of immunoglobulin antibodies, especially when somebody eats food that cause allergies. They really stimulate the release of immunoglobulin E antibodies, and this immunoglobulin E binds to receptors on the surface membrane of the mast cell or basophil, and a series of reactions occur and lead to degranulation of the mast cell. And so histamine and other compounds are released eventually. This mechanism is energy dependent, and the histamine inhibits its own release in skin mast cells and blood basophils by binding to histamine 2 receptor, which means this histamine type 2 receptor gives a negative feedback, and this feedback inhibition doesn't occur in lung mast cells. So sometimes we have those coughs that are generated as a result of the release of histamine. That's why when you cough, have dry cough, that irritation is as a result of generation of histamine, and it can be inhibited by administration of antihistamines, especially antihistamines that work on histamine receptor type 1, and those are the drugs that come into play to relieve patients from restlessness and also controlling some challenges concerning the people who have just probably undergone some surgical procedures to stop the opening of the scission or tearing of the sutures that have been done. And so, for non-antigen mediated release of histamine, it doesn't. The histamine is released irrespective of what happened. No prior sensitization of the immune system is required. So it can be as a result of drugs, peptides, venoms, and other agents that displace histamine from heparin protein complex within the mast cell. And sometimes it can come as a result of mechanical injury that causes trauma, as I said earlier. And this increases proliferation of mast cells and basophils, like in leukemia and gastric carcinoid tumors, and other stimuli can also cause that, like cold, bacterial toxins, urticaria, and many others. These actually cause a number of release of histamine. We also see that these histamines can be inactivated once released. They can be immediately inactivated. And this comes as a result of metabolic reactions, primarily through two ways. One, it is broken down by histamine N-methyltransferase catalyzed transfer of methyl group from S-adenosyl 1-methionine to substitute one of the imidazole nitrogen. And this actually brings about decrease in the amount of histamine, hence inactivating. And there are many other related enzymes that probably you have got from biochemistry. But alternatively, there could also be, not really there could, but there is also an alternative pathway of inactivating this histamine. Once it is released, it is inactivated by oxidative deamination by enzyme diamine oxidase or histaminase, which actually causes inactivation. And the diamine oxidase is present in both tissues and blood and plays a particular role in metabolizing the large concentration of histamine. and so that causes the inactivation. Now, to produce its effect, histamine goes through acts through histamine receptors. There are 4 different types of histamine receptors, and these histamine receptors are G-coupled. They work through stimulation of glycoproteins and lead to generation of series of reactions that bring about the physiological changes, and that's how we get the reduction in inflammation or disappearance of pain from the body. However, the commonest that are known are histamine receptor type 1 and histamine receptor type 2. They are located in different tissues, and they are targeted for clinical use of such drugs in affecting reducing the effect of histamine. Especially when we want to cause pain or when we want to reduce pain, we target the histamine receptor type 1 and histamine receptor type 2 to help us use them, the antihistamines or histamine agonists clinically. They have drugs that are of clinical use. For example, we have the agonists that are commonly used in affecting or in reducing some pain or inflammations in various parts of the body. And these histamine receptors are distributed all over. Especially, they are commonly found in smooth muscles, on smooth muscles, the endothelium, brain, histamine receptor type 1. Then histamine receptor type 2 are found in gastric mucosa, cardiac muscles, on mast cells. They're also located in brain and so forth. There is another histamine receptor type 3. They are presynaptically located in the brain, mesenteric plexus, and the other neurons. There are many agonists and antagonists that can be used, especially a typical antagonist that is selective for histamine receptor type 1 is mepyramine. And then another example of histamine antagonist for receptor type 2 include ranitidine, we have loratadine, cimetidine, famotidine, and even loratadine, as I said. So these tend to inhibit histamine receptor type 2. For histamine receptor type 3, the antagonist, the example of antagonist is theoperamide. So there could be many others that we will include later when we manage certain conditions pharmacologically. We also see that many of these drugs are of clinical use. Generally, in clinical application, most of them are used in reduction of in management of cardiovascular disorders, and especially in reduction of blood pressure. They do this reduction in blood pressure by causing vasodilation on the arterioles, capillaries, and venules following an IV injection. And these go to affect the histamine receptor type 1 and receptor type 2. And so they can also be used to increase cardiac contractility and heart rate via histamine 2 receptor type 2, and they can also cause increase in permeability of capillaries, and so many. That's why they are of clinical importance. In the central nervous system, the histamine is a neurotransmitter, and it stimulates the histamine receptor type 1 in the central nervous system to mediate the maintenance of wakefulness. So when you are awake, it means the histamine is overstimulated. The histamine receptors are overstimulated to cause the CNS to remain awake. So these histamine receptors, both histamine receptor type 1, type 2, participate in regulation of blood pressure, body temperature, fluid homeostasis, and pain sensation, while the presynaptic receptor type 3 serves as a feedback inhibitor of the release of histamine and norepinephrine and other neurotransmitters. So they tend to act as modulators at a certain point. While on the peripheral nervous system, the histamine receptor type 1 on the sensory neurons in the epidermis and dermis mediate itching and pain. That's why we have the allergic reactions that can cause itching and pain, even sometimes anaphylactic shock, leading to anaphylactic shock, or anaphylaxis is actually caused as a result of release of histamine. In the respiratory system, they cause contraction of bronchioles, leading to bronchoconstriction when histamine 1 receptor is stimulated by histamine, but they can be stopped by using antihistamines. In the JET, the histamine can cause contraction of the intestinal smooth muscles, leading to peristalsis, so increasing peristaltic movements. That is if histamine receptor type 1 is stimulated by histamine. So it usually stimulates gastric secretions, leading to a lesser extent stimulate gastric pepsin and intrinsic factors to be produced, but mostly these gastric secretion and pepsin release are stimulated by histamine receptor type 2. Clinically, histamine is used as a positive control injection during allergy skin testing. So in summary, histamine 1 receptor, histamine receptor type 1, histamine receptor type 1 mediates many physiological processes, including allergic rhinitis, atopic dermatitis, conjunctivitis, urticaria, bronchoconstriction, asthma, and anaphylaxis. While histamine receptor type 2 mediates an increase in acid secretion, which is a corrosive factor or a stress factor in causing ulceration. And generally, we use antagonists to reduce the effect of histamines in the body. And these actually cause physiological, they resolve physiological disorders, like where there is excessive release of epinephrine, the histamine can oppose its effect. Then the antihistamine can oppose its effect. And then we also have use of, they can be used to cause release, to inhibit the excessive release of histamines, that is the antagonist, which actually sometimes can bring about degranulation. So to stop the degranulation of mast cells, we use antagonists like chromoline or chromoline, depending on how you pronounce it. We can use histamine receptor antagonists to oppose the allergic reactions that occur in the body. And so there are many that are used. For example, they can be classified into first and second generations, and there are many antihistamines, which we call as histamine receptor antagonists. There are many. They fall under the class of first and second generation. Examples of first generation antihistamines include diphenhydramine and phenylamine. Then we have cyclizine, we have chlorpheniramine, we have promethazine, and these are actual first generation antihistamines. So in classification, we have in classification of antihistamines or histamine antagonists, we can have the antihistamines as the H1 blockers and H2 blockers. And the H1 blockers are classified into first generation and second generation. First generation include meclizine, diphenylamine, while the second generation of H1 blockers include cetirizine, loratadine, famotidine, and so forth. While on histamine receptor type 2 blockers, we have cimetidine and ranitidine. So they are commonly used in management of these common conditions of anaphylaxis and allergies. Much as they are useful, they have their own challenges, like they have some unwanted effects. They cause sedation, they cause nausea and vomiting, they can cause some form of anti-Parkinson's effect, which may not be as required. They have certain anticholinergic receptor actions where they can cause blood vision, urinary retention, they can cause some kind of rhinorrhea. These are unwanted. They also have certain effects in causing in blocking adenoceptor action, meaning they tend to inhibit the release of norepinephrine. So, especially the histamine receptor type 1, they can cause reduction in release of norepinephrine. Typical examples include promethazine. This may cause orthostatic hypotension in susceptible individuals, which means when you take some of these promethazine, you don't need to really stand up very fast. You need to relax and stand up slowly, otherwise you can suffer from hypotension, which is orthostatic, or you really need to rest before you move. Then they also have serotonin blocking effect. It has been demonstrated and realized with the cyproheptadine. And in addition, the antihistamines, like promethazine, like meclizine, and other related effects, other related examples, they the first generation, especially loratadine, tend to have local anesthetic effect. They block sodium channels in excitable membrane in the same fashion as procaine and lidocaine do. So it makes it very hard for them to be used by some people who have certain contraindications for such conditions. So when you are using these antihistamines, be careful. Clinically, we use it in management of Allergic reactions, we use it in management of motion sickness like promethazine. Allergies can be treated with citizen. We can also use it to help people sleep because it has got sedative effect. We can treat insomnia using antihistamines like doxylamine can be used. They can be used as local anesthetics like diphenhydramine and promethazine. They can be used as local anesthetics, though they have effect of causing convulsions at a certain point, dry mouth, even causing sedation. While the H2 blockers, these antagonists, we call them as blockers because they also block the effect of uh, histamine. So there are H2 blockers and the H1 blockers. The H2 blockers are used in treatment of peptic ulcer, especially cimetidine, ranitidine, loratadine, and so forth. The only side effects we have seen commonly with these H2 blockers include uh, dizziness, constipation, gynecomastia, or sexual dysfunctions, especially in males. So they should be used with care and when you have informed the patient. Otherwise, it will cause family breakdown due to non-satisfaction of the partners, which is not healthy. So you must counsel these people before, it's important that you need to make sure they are satisfied of what is happening. So generally, most of these antihistamines are orally administered. Coming to their pharmacokinetics, they are generally orally administered, they are widely distributed, they are extensively metabolized by the cytochrome P450 in the liver, and in most cases, they also interact. They cause interaction, which means some of them are inhibitors of cytochrome P450 and others are inducers. So, especially the second generation agents are metabolized by cytochrome P450 and therefore they are subject to important interactions when other drugs like ketoconazole are used. This ketoconazole inhibits the cytochrome P450 enzyme, and so that can cause an increase in the levels of the second generations like the citizen. When they are used, they can cause accumulation with repeated dosing up to toxic levels. So care must be taken when these drugs are used concurrently with or in combination with certain other drugs. So most of the drugs have effective duration of action between 4 to 6 hours after a single dose, but meclizine and several other second generations are longer acting, up to maybe 12 to 24 hours. That's why their duration, their frequency of administration is twice a day or even sometimes once a day. After all, these drugs are used where necessary, when they are really indicated. Don't use them for the sake of causing unwanted effects like sedation. That is a drug abuse, which is not okay unless it is indicated. We should not abuse these drugs, otherwise we shall end up causing more problems to the patients than helping them. Another autacoid is serotonin, and serotonin is a local hormone that plays a major role in migraine headache. Not even distributed, it's not evenly distributed, but highly concentrated in enterochromaffin cells, in the JT, platelets, serotonergic neurons, the nucleus of Raphi, in the brain stem, and mast cells. So that's where you get this serotonin located. Now, it's also present, serotonin is also present in venoms of vertebrates and insect stings. That's why when the insects sting, you feel that burning sensation, and it's as a result of the presence of serotonin. Structurally, serotonin is an endoethylamine derivative of L-tryptophan. That's why you find the chemical name of serotonin is 5-hydroxytryptamine. So it is a derivative of L-tryptophan that is aminated to form the tryptamine. And so the L-tryptophan is a precursor which is hydroxylated in the indole ring and then decarboxylated to form the serotonin. It usually occurs in two steps, which is catalyzed by hydroxylase and decarboxylase, respectively. And after the synthesis, free amine is stored in the cells and is rapidly inactivated, usually by oxidation catalyzed by enzyme monoamine oxidase. So, serotonin is also a monoamine, and so the release of serotonin is due to mechanical or neuronal stimuli that can cause the release of this serotonin. And usually, the pharmacological effects are found mostly realized in neuron system. Serotonin itself is a neurotransmitter in the CNS that mediates moods, sleep, appetite, pain, temperature regulation, and vomiting, as well as blood pressure. So this is a very important autacoid which has cut across to cause so many effects in the body. And we have also found that it is involved in the pathogenesis of depression, as well as anxiety and migraine headache. And so this is its effect in the central nervous system. But in the peripheral, like histamine, serotonin is a stimulant of pain and itching. So they have the same effect with the histamine in the periphery. Especially, they cause itching and pain at nerve endings, and they are responsible for some of the symptoms caused by insects and plant stings that we always experience. And so, while in the airways, serotonin causes hyperventilation as a result of chemoreceptor reflex or stimulation of bronchial sensory nerve endings. And in the cardiovascular system, serotonin causes vasoconstriction through the 5-TH or serotonin receptor type 2, except in the heart and skeletal muscles where it causes vasodilation. So it also causes platelet aggregation by activating surface uh, receptor, that is 5-HT type 2, that is the serotonin receptor type 2, which is found on the platelets. And once it is stimulated by serotonin, it causes platelet aggregation, which is a pathophysiological pathway. Pathophysiological pathway for the cause of what? For the cause of maybe clotting or even hemostasis of certain kind. So that way, it helps us to understand, maybe do more research in how to help resolve certain embolisms that occur in circulatory system. In the GIT, serotonin is a powerful stimulant by the epinephrine, and so in the pineal gland, serotonin is the precursor for the synthesis of uh, melatonin, and melatonin is a very serious hormone which causes a number of effects in our body, including determining the color of our skin, which is dependent on the melatonin, even including the determination of IQ is on the melatonin. Melatonin has a lot. it has got its own science. So how we think, most of our structures are attributed. I mean, the color, the IQ, the, the functionalities, some of them are more attributed on the melatonin. So, serotonin as a mediator activates its own receptors, which are about 5 types. We have 5-HT type 1, 5-HT type 2, type 3, type 4, and so forth. And their locations are in various parts. And for example, the receptor, serotonin receptor type 1 is located in the brain, hippocampus, basal ganglia, and the other parts of the brain. While the type 2 are found on the platelets, smooth muscles, and cerebral cortex. And the type 3 is mainly found in the GIT, gastrointestinal tract. Then we have even on the sensory nerves, while the type 4, type 5 are common in the brain. So, clinically, serotonin has no application as a drug. Its receptor antagonists actually have therapeutic uses, but serotonin as an agonist doesn't have a therapeutic use, but rather we use its antagonists clinically to stop certain effects. Typical examples of serotonin antagonists include bacipiron or bacipiron. Some people call it bacipiron or bacipiron. It inhibits receptor type 1 of serotonin and reduces anxiety, which is sometimes known as anxiolytic. Then we have another antagonist called sumatriptan and several other triptan, which is selective for receptor type 1D, type 2B, and used in treatment in acute migraine. So where there is migraine headache, we go for sumatriptan, or cluster headache attacks where your headache is happening at particular parts of the body, parts of the brain or of the head. We can use sumatriptan. Then we also have cisapride, which is a 5-H4 antagonist. It is a prokinetic agent used in treatment of gastroesophageal reflux disease and also motility disorders, where there is some challenges in motility of the JT. Then we have tegaseroid, a new receptor type 4 partial agonist used in irritable bowel syndrome with the constipation. There are others like fluoxetine, which inhibit serotonin reuptake, and it is clinically used to treat depression. So, in order to mobilize serotonin at the synaptic cleft to continue stimulating the receptors to reduce the depression and improve moods. We also see that there are other indirect receptor antagonists like resapine, which inhibits storage of serotonin by stimulating its release, but later cause the depletion of serotonin and cause more negative effects. So fluoxetine and other selective serotonin reuptake inhibitors inhibit the reuptake of serotonin into the nerves. Then we also have chlorophenylalanine and the chloroamphetamines that inhibit the synthesis of serotonin. And so, as my time is coming to an end, I just want to conclude that these drugs also are used in other clinical conditions, as you have heard, in treatment of anxiety, depression, peptic ulcer disease, urticaria, other anaphylactic episodes, and so forth. We also have other clinical applications of serotonin antagonists, like for example, we have cyproheptadine, which is a potent histamine receptor 1 blocker, but also it blocks the serotonin receptor type 2, and it is used in treatment of smooth muscle manifestations of carcinoid tumors and in the post-gastrectomy damping syndrome. And those also are used in cold-induced urticaria and as appetite stimulants in children, especially the cyproheptadine. They can be used. These, some of them like the clozapine, also block 5H receptor type 2 and is used in management of anxieties. That is as one of the anxiolytics. Then we have the ketoserine, which are serotonin receptor type 1 blockers. They're used in treatment of hypertension and vasospastic conditions, while ondansetron, which is a typical antagonist of serotonin receptor type 3, is used in prevention of nausea and vomiting associated with the surgery and cancer chemotherapy. And other members are grainsatron and dolasetron. Then we have allosetron, which is used in irritable bowel syndrome treatment. And these are rare drugs that are used when required. And that's what I want to stop at. We have just tackled histamine and its receptors as typical autacoids with their clinical applications. Then the other one is serotonin, which is a typical autacoid that is widely distributed mainly in the brain, and also it has its effect on the skin to cause anaphylaxis and allergic reactions like histamine. So these two have common. Even there are some drugs that tend to work on a common receptor, like the clozapine, the ketoserine, and other related drugs that are having cross-cutting histamine, the receptor blocking effect. So we'll be able to continue with this lecture in the second lecture, where we shall be having the bradykinins. We shall also be having the bradykinins, their synthesis, and prostaglandins with their synthesis, and other autacoids that get produced in the system. And here I beg to end this lecture. Wish you well. You will only follow this on my YouTube channel, and you can tap the like button if it is helpful to you. You can also continue to give your comments to improve this video, and I welcome you. We shall continue to improve this video. It is to help some of the students who may not have time to access lectures due to certain challenges, but when they log on the YouTube channel, you'll be able to access this lecture at your convenient time. Wish you all the best. Bye. And here I beg to stop.